Okay, now when we talk about asthma, asthma for the most part is treated very similar to the way that we treat COPD. There are a couple things that are a little bit different about asthma that are worth mentioning. The first thing is, remember that when we talk about asthma, asthma is actually broken down into two phases. When you have an acute exacerbation of asthma, when you have a severe asthma attack, remember that the first phase is actually bronchospasm. When we very first start to have that exacerbation of asthma or really, really bad asthma in the form of status asthmaticus, the big thing that happens right off the bat is we have massive bronchospasm. Now, the bronchospasm obviously is the paramount thing that has to be treated the fastest. We've got to get rid of that or the patient's going to die. But there's a second phase to an acute exacerbation of asthma that occurs a couple hours later. And basically, a couple hours later, the big thing that happens is these patients really start to swell in their airways, and their airways become really, really inflamed. A large part of that is probably because of all the turbulent airflow that's occurring while they're bronchospastic. Now, when we talk about management of asthma, the big thing we use to treat asthmatics, or the big way that we make decisions about their care, is actually with something called their peak expiratory flow rate, or their PEFR. The PEFR is how well the patient can blow out. And we actually use a device similar to what you see in the picture above me here to figure out what their peak expiratory flow rate is. Now, when we talk about peak expiratory flow rates, there's some generalizations out there, like typically in males, an average PERF is somewhere around, an average PEFR is somewhere around 500 to 700 liters a minute. For a female, it's somewhere usually around 380 to 500. And for a child, there's a formula which is 13.33 times the height in inches minus 4.26.52. Like you're ever going to remember that in an emergency. What we're more focused on instead, those give us some ideas, but what we're more focused on is what the patient's PEFR is. That's really what's more important to us. And so if a patient has been tolerant with their meds, if a patient is seeing a physician and their asthma is being managed, one of the things that they should be able to tell you is what a normal PERF is, a normal PEFR is for them. They should have what's called a personal best. And so the way they figure out their personal best is they usually keep a diary, and they know that over time, when their asthma is under good control, they know that they have a peak inspiratory flow rate of X. So for instance, they may know, if it's an adult male, he may know that my normal PEFR when I'm well treated is 600 liters a minute. And when we talk about management of asthmatics, really what we target our treatment towards is in their exacerbation, when we're seeing them now, what is their PEFR compared to what their personal best is. And if it's at least 70% of what their personal best is, then typically we would say that that's a relatively mild asthma attack. If their percentage right now while we're treating them is between 50 and 70% of what their personal best, then we would say that that's moderate. If it's less than 50% of their personal best, then that's a severe asthmatic attack. And if it's less than 30% of their personal best, then that by definition typically is respiratory failure, and a lot of times we're going to have no choice for those patients but mechanical ventilation. Okay, so when we talk about the treatment for these patients, again, is very similar to the way we treat COPD with a couple of exceptions. One of the big things that we do for these patients is, just like our COPD patients, we use our first-line drugs as sympathomimetics, beta-2 sympathomimetics, and anticholinergics. Those are most of the time what reverse a lot of patients with asthma. And interestingly enough, a lot of times patients with asthma, even asthma that's significant enough to present to the hospital, can be treated just with nebulization. A lot of times the biggest thing that decides whether or not somebody's successful in nebulizing themselves is whether or not they're doing it appropriately. And a lot of asthmatics will neb themselves multiple times at home, but they're not getting good nebulization because they're not getting good vital capacity breaths. And if they have somebody there to coach them and to walk them through, a lot of times those patients will respond to those nebs much better than they would their nebs at home. When we talk about additional things we do for these patients, steroids are very critical to the management of asthma. One of the biggest things we do to manage asthma on a long-term basis now, one of the number one things we do to control asthma is the use of steroids. We found that pro-inflammatory response that creates asthma in the first place responds very well to steroids, and so steroids should be a major tenet of asthma treatment. Our asthmatic patients should certainly be treated with steroids. Some other things that we may try for these patients, we may try giving them magnesium. When we talk about giving magnesium, remember that magnesium is a smooth muscle relaxer. The thought process is that it probably binds the release of calcium into muscles, which is what causes muscles to contract. And while the research has been kind of pro and negative, there's still a lot of anecdotal research out there, or anecdotal experience out there that has made magnesium a pretty commonly given drug in asthma. Some other things we can do for asthmatics: if the patient is relatively young, we may use ketamine. We can use ketamine for a couple reasons. We can use ketamine for the actual induction if we have to intubate them, which we're really hoping that we don't have to do, just like the COPD. But if we do, we can use ketamine for that. And the other thing is, a lot of institutions, especially in pediatric patients, will actually put patients on ketamine drips. And remember, the big advantage to ketamine is that it is a profound bronchodilator, works very well for bronchodilation. Now, when we talk about antibiotics for these patients, like the COPD patient, there's a lot of argument out there about whether or not to give these patients antibiotics. And basically what it boils down to is, are there clear and convincing signs of infection? If you believe that the patient's infectious, the patient probably needs to get antibiotics as part of their treatment for their exacerbation of asthma. But most of our asthmatics probably don't need antibiotics. There's probably not a need for most acute exacerbations of asthma to get antibiotics. Another big argument that was sustained for years was whether or not to give these patients fluids. For years, we pushed in education that asthmatics are dry, asthmatics have lots and lots of mucus, you need to give those patients lots and lots of fluid, and the thought process was that because they were dry, we needed to give them fluid, and by giving them fluid, we would help to break up the mucus. That is no longer the case. I'll say that again. That is no longer the case. And there's a couple reasons why we don't advocate just blindly giving fluid to asthmatics anymore. The first one is that there's been a couple of research studies that have looked at giving fluid to asthmatics who already are not hypovolemic, and they've actually found that the more fluid you give patients, the more you actually decrease their tidal volume. So for some of those asthmatics, you may actually see as much as a drop in their tidal volume, as much as 6 cc's per 500 cc bolus. So 6 cc's of tidal volume drop from 500 cc's of fluid. And that may not sound like a lot, but especially in some of your little kids, that can actually be pretty profound. You can see pretty significant drops in tidal volume with giving excessive fluid. The second reason why this whole argument was really bogus in the first place was that we used to say the whole reason we were giving the fluid was to break up mucus. That's the same reason why we used to shoot fluid down ET tubes, to help break up mucus. Well, if you've ever had the pleasure of having bronchitis or asthma or anything like that, and you've ever coughed up a loogie and spit it into a sink where there was running water, you know that mucus isn't water soluble. Mucus doesn't break down in water. Mucus is thicker than water. You don't have to be a chemist to figure that out. So that whole thought process about, oh, we need to give them lots of fluid IV and we need to give them lots of fluid down their throat to break up mucus is really probably a bogus argument, because that doesn't break up mucus. So does that mean that no asthmatic should get fluid? No, not at all. All that we're saying now is that the decision to give the asthmatic fluid should not be blind. It should be based on actually assessing the patient. And if the patient's truly dry, if the patient is truly dry because they've been losing, like let's say they've lost a lot of fluid over time because they've been in this exacerbation for several days and they've lost a lot of fluid just by breathing, then certainly that patient needs fluid. But if the patient doesn't appear to be dry, don't blindly just give them a bunch of fluid. Okay, some other things that we can do for these patients. Another big thing we may do for these patients is we may put them on Heliox if nothing else works. And remember, Heliox is just a mixture of helium and oxygen. And the whole reason why we would put somebody on Heliox is because Heliox is 6 times less dense than air is. So helium helium is it's very small molecules, it's very non-dense, and those tight little airways that we may not be able to get air through, we can get heliox through because of the fact that there's so much helium there. So it allows for better diffusion of gas in the lungs. And it comes in various mixtures. The typical mixture that most people use is a mixture 70-30, so that would be 70% helium, 30% oxygen. And a lot of times that will rescue patients that we can't rescue other ways. Now finally, some last notes when we talk about non-invasive positive pressure ventilation. There have been a couple studies that have looked at using things like things like CPAP and BiPAP for patients with asthma, and they have shown some promising results, although I wouldn't say that it's a mainstay of treatment yet, but it's certainly something that can be tried, especially for the patient where you're not totally convinced it's asthma, or you're still kind of in that working phase trying to figure out exactly what's wrong with them. And finally, when we talk about mechanical ventilation, the rules for asthma are just like the same as the rules for COPD. We want to do whatever we possibly can to avoid intubating these patients if we can. Our whole focus in life is to try and avoid intubating these patients. If we've tried to rescue them by using beta-sympathomimetics and anticholinergics, we've put them on steroids, we've tried magnesium, we've tried heliox, we've tried, say, a trial of non-invasive positive pressure ventilation, and they're still flailing, then obviously we have no choice but to put them on mechanical ventilation. But again, we want to use low tidal volumes, long expiratory times, just like with COPD patients. You want them to have a long time to breathe out, and again, you want them to do as much of the work as you can. So a lot of times we may only start an adult on, say, like 4 to 6 cc's per kilo, and we may only start them on a ventilatory rate of, say, 6 breaths a minute. That way they're doing most of the work, the ventilator is only augmenting them, and again, just like with the COPD patient, we want to get this patient off the ventilator as quick as we can. Okay, when we look at an x-ray for somebody who's got asthma, the big thing that we're going to see is hyperinflation. So when we talk about hyperinflation, how do we categorize that on a chest x-ray? Well, there's basically 3 things that tip us off to hyperinflation on a chest x-ray. The first thing that would tip us off is actually what's called blunting of the diaphragm, or blunting of the costophrenic angles. Remember, the costophrenic angles are those corners where the diaphragm comes up against the rib, and we would normally like to see that those are less than 45 degrees. As they become more than 45 degrees, we know that that's telling us the diaphragm has been pushed down, and so that suggests to us that the patient is hyperinflated. The second thing that you'll note on this chest x-ray that really tips you off that this patient's really hyperinflated is you don't see a lot of pulmonary markings. The lungs look very, very black. Well, those lungs are very, very black because they're so engorged with air that the patient doesn't have a lot of space for movement of blood in the lungs. So this in and of itself can cause problems with oxygenation and ventilation transport. If we can't get blood to the lungs, this can cause a shunt. And finally, the third thing that really tips us off here is the fact that we see this patient's heart has really been compressed, and that is obviously not a good thing because that's going to decrease our cardiac output. And interestingly enough, when you look at this chest x-ray here, you see that this is a patient who's intubated, and this is a great example of why intubation doesn't necessarily help patients with asthma, COPD, or chronic bronchitis. Sticking a PVC pipe down somebody's throat, sticking an ET tube down their throat, does not help them breathe out. So when we do make the decision to intubate, it's got to be because they've both got a problem with breathing out and they're so exhausted they have a problem with breathing in. We know that it's a temporizing measure. We know that we only want to intubate as a last resort, and we know that we want to get that ET tube out of their throat as quickly as we possibly can. Okay, when we talk about spontaneous pneumothorax, this is another thing that we may see occasionally in emergency medicine or in the ICU. Typically, when we talk about a spontaneous pneumothorax, it usually occurs in young people. A lot of times it happens in people that are very thin and very tall. It may be related to an actual structural abnormality in the lung, or it may just be idiopathic, which we all know is our fancy medical way of saying we don't know why it happens. The classic thing that we see with the spontaneous pneumothorax is the patient has a sudden onset of shortness of breath and sharp pleuritic pain. So they have this sharp pain that's reproducible when they inhale and exhale, may or may not be reproducible when we push on the chest, and a very significant shortness of breath. A lot of times these patients will have a cough, and sometimes the cough in and of itself may be significant enough that that's actually what causes the pneumothorax. Classic other things we'll see with these patients, a lot of times we'll see tachycardia or tachypnea, and interestingly enough, about 90% of spontaneous pneumos actually occur in people who are smokers. Now, when we talk about the management of these patients, obviously the management is on the focus of the management is actually going to be on relieving the pneumo. Now, the first thing we want to do for these patients is we want to give them oxygen, obviously to improve their oxygenation and to make it easier for them to breathe. And then we need to make a decision about what we're going to do about the pneumo itself. And as a general rule, if the pneumo is less than 15%, if a pneumo is less than 15%, if it's a small pneumo, a lot of times we can treat these patients just by putting them on a non-rebreather. A lot of times if they're on a non-rebreather, that in and of itself will relieve the pneumo over time. A lot of times if we take these patients from a non-rebreather and keep them on a high flow of oxygen, like as high as we can get on the non-rebreather, 70-80%, whatever we can get, for a period of 24-48 hours, a lot of times these patients, their pneumo will resolve on its own. Because over time what will happen is that air that's in the potential space will become replaced with oxygen, the body will absorb the oxygen, and the pneumo will fix itself. Now, what about the patient that can't wait that long? What if the patient's got comorbid problems? Let's say they're also an asthmatic and blah, 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 blah. Well, then if the pneumo is less than 15%, then a lot of times the other thing that we can do for these patients is we can just do a needle aspiration. So we would actually just take a needle and actually suck out the pneumo with a syringe. Now, when we talk about doing the needle aspiration, obviously that's something that we typically would want to do with some kind of invasive guidance, whether we're doing that with ultrasound or whether we're doing that with fluoroscopy or something like that. That's typically what we'll do for those patients. But if the pneumo is more than 15%, or if the patient has comorbidities, or if the patient is unstable, then we really need to start thinking about putting a chest tube in this patient. So again, if the pneumo is more than 15%, or if the patient has multiple comorbidities, or if the patient is unstable, needle aspiration and 100% oxygen is not going to get it. We probably need to actually put a chest tube in that patient. Okay, here's a good example of a spontaneous pneumothorax here. Remember, the big thing we're looking for when we look at a pneumothorax is the big things that we're looking for when we're looking at a chest x-ray and looking for a pneumothorax is we're looking for a clear line where the lung stops. Now, one of the things that will often catch people and one of the things that will make incorrect diagnosis of a pneumo that's not there, or people saying there's a pneumo when there's not really one, is seeing a line on the lung that goes from superior to anterior and thinking that that's the line of the lung, when in reality it's actually just the scapula on the back. When we're looking for the pneumo, remember the thing we're looking for is that clear line, and past the line, as we go more lateral, we should see no vascular markings. If you see a clear line, but you see vascular markings that continue on as we go more lateral, then that's not a pneumothorax. With a pneumothorax, we will have a clear line of demarcation where the lung ends, and there won't be any vascular markings past that. So when we look at this chest x-ray right here, you can see when we look at this patient's right side, this patient, this is a chest x-ray where the patient is facing us. When we look at the patient's right side, you can see there is a clear line of demarcation that starts right about the middle of the clavicle and goes down, and you'll see that there are not vascular markings beyond that. Okay, when we talk about pulmonary emboli, remember that pulmonary emboli are caused because of an obstruction of blood in the pulmonary artery. Depending on where the obstruction of blood is, depends on how bad or how big the pulmonary embolus is. Obviously, a blockage in a terminal point of a pulmonary artery would not be as big a deal as a blockage of one of the main stems of the pulmonary artery. Now remember that with these patients, obviously these patients have a true shunt that is created because they have oxygenation and ventilation occurring in their lungs, but there's no blood coming by to pick up that oxygen. There's no CO2 being dropped off, so these patients end up in both hypercapnic and hypoxic respiratory failure. When we talk about the treatment for these patients, the big thing we want to do is obviously we want to oxygenate them. We may have to intubate these patients. We also want to consider coagulation if we think that the pulmonary embolus is because of hypercoagulation. So for instance, like if we think this is because of a DVT, we would consider something like heparin. We also might consider fibrinolysis if this is a clot that again is because of a blood product, again like a DVT. And the big thing we do for these patients is we take them to surgery or we take them to invasive radiology where they can actually remove the clot under fluoro. And this picture right above me is a great example of a huge pulmonary embolus. This pulmonary embolus has occurred in one of the main branches of the pulmonary artery that shoots up and supplies the upper lobe, and all that white area that you see is a white area that is not being perfused, and thus all that white area is shunted and there's no blood flow there. Okay, when we talk about pneumonia, just a couple of quick things about pneumonia. When we talk about pneumonia, it's a really simple disease to understand. Remember, the big thing with pneumonia is that we have some kind of infection that presents itself down in the terminal portions of the lung, and the body does what it does anywhere there's an infection. It sends all of its pro-inflammatory stuff, which is all your stuff like white blood cells and all your excess fluid because of mast cell stimulation and all that good stuff. And the big problem with pneumonia is, well, that's a good thing. It's helping to kill whatever virus is there. The problem is all that stuff that's there to kill the virus is taking up space in the lung, and therefore we don't have oxygenation and ventilation there. Now remember with pneumonia that pneumonia is caused because of an infection in the lung, and because of an infection in the lung we're going to have a pro-inflammatory response, and we've already talked about how ARDS is caused by an excessive amount of inflammation. So when we talk about pneumonia, the big reason why pneumonia is such a big deal is because it's not a big stretch for people to go from being pneumonia patients to being ARDS patients. Now when we talk about causes for pneumonia, we usually break pneumonia up into two types of pneumonia, and this is more a logistical concern than, say, a clinical concern. VAP is ventilator-acquired pneumonia, and ventilator-acquired pneumonia occurs when the patient doesn't have pneumonia, is intubated, and gets pneumonia while under positive pressure ventilation. In contrast, CAP is community-acquired pneumonia, and this is like the patient who gets pneumonia out in the environment and then brings it into the hospital presenting with signs and symptoms of pneumonia. When we talk about organisms, obviously any kind of microorganism can cause pneumonia, whether it's a viral, whether it's bacterial, whether it's fungal, any of those types of things can cause pneumonia, but our focus is typically on bacterial pneumonia. Most of our pneumonias are bacterial, and luckily we also have ways to treat bacterial pneumonia. Okay, now when we talk about pneumonia treatment, the big thing with pneumonia, the thing that whether it's CAP or VAP doesn't matter, the big thing that we need to understand is that the very first, most basic tenet of managing pneumonia is we have to maximize oxygen delivery and minimize oxygen demand. So when we talk about optimizing oxygen delivery, that means putting the patient on oxygen. That means making sure the patient's got enough circulating blood volume to move oxygen. That means making sure the patient's got plenty of cardiac output. And when we talk about minimizing oxygen demand, we're talking about things like controlling the patient's temperature, controlling hypermetabolism, controlling activity, things like that. And when we can create a balance between oxygen supply and oxygen demand, then that gives the time the patient needs in order to heal. If we can't do that, then those are the patients who become even more pro-inflammatory and a lot of times transition into ARDS. Now, when we talk about specific treatment for community-acquired pneumonia, there are some generalizations that are pretty important. One of the things that we know is that the earlier antibiotics are given, the better the patient's chances are that they're going to survive. So we typically say we want to give the patient antibiotics within 4 hours of admission. And remember, admission means admission to the ED department, not admission to the floor. So if the patient has not had antibiotics within 4 hours, that needs to be done ASAP. And remember, obviously, before we give antibiotics, we need to get blood cultures, and remember that it's not uncommon for patients with pneumonia to have normal blood cultures. One of the other things that may help is also getting sputum cultures if we have the ability to do so. But if the patient has a life-threatening pneumonia and it's really, really bad, ideally we want the blood cultures and we want the sputum cultures first, but if we can't get them, we need to start the antibiotics. Now, when we talk about the choices for antibiotics, there's guidelines that determine how we treat pneumonia, and they're changed every couple years, and the most recent guidelines came out in the end of 2007, and they recommend for patients who are being treated outpatient for pneumonia, we typically can start those patients on a fluoroquinolone, or we can start those patients on a beta-lactam drug and a macrolide. You have your choice, one or the other. You can either start them on just fluoroquinolone, or we can start them on a beta-lactam and a macrolide together. For patients that are going to be admitted to the hospital, specifically patients that are going to be sick enough to be admitted to ICU, which is what most of us are going to deal with, typically the recommendation is that you put those patients also on a fluoroquinolone or that we put those patients on beta-lactam and azithromycin. And those choices in antibiotics are very much driven by what's present in the local community, and also by changes in practice and changes in evidence with regard to infectious disease. So those things change pretty commonly, but as things stand now at the time of this taping, which is early 2009, the recommendation is a fluoroquinolone or a beta-lactam and a macrolide for patients who are outpatient, and for patients who are going to be admitted to the ICU, we give them a beta-lactam with azithromycin, or we give them a fluoroquinolone. Now, what about VAP? Let's talk about VAP for just a few minutes. When we talk about VAP, or ventilator-acquired pneumonia, the first thing that we have to understand is where VAP comes from. And this is an important point, because for years, VAP was a major concern in the ICU. It still is even today, but it was a really major concern that we just had no clue about where it came from, why it happened, blah, 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 blah. For years, the thought process was that the reason people got ventilator-acquired pneumonia was because organisms traveled down the lumen of their ET tube. We thought a lot of it had to do with things like hand washing and things like that, and we did all these things that were aimed at healthcare workers, and blamed a lot of ventilator-acquired pneumonia on the fact that they were contaminating things inside the ET tube, and blah, 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 blah. We now know that that is not the case. Again, I'll say that again. That is not the case. Ventilator-acquired pneumonia does not come down the ET tube the vast majority of the time. Instead, what we now know is that ventilator-acquired pneumonia most times actually comes from stuff in your mouth. It actually comes from the microbes and the things that are in the floor of your mouth. As you are intubated, as you're sitting there laying down, the stuff in your mouth drains down your throat, and because most patients don't have a complete seal of their trachea with the ET tube, contrary to what we like to believe, most patients do not have a complete seal of the trachea with the ET tube cuff. So as that stuff travels down your throat, it actually travels around the cuff of the ET tube, down your trachea, and then with positive pressure ventilation, it's disseminated into your lungs, and that is what causes ventilator-acquired pneumonia. So most of our ventilator-acquired pneumonia doesn't come down the lumen of the ET tube. Instead, it comes from around the ET tube cuff, and it comes from the floor of our mouth. Now, we figured out there's some things that we can do to decrease the chances of ventilator-acquired pneumonia. One of the first things that we found that was majorly instrumental in controlling ventilator-acquired pneumonia was actually really good oral care. And when we talk about oral care, we're talking about doing all that stuff to keep the mouth clean, using the toothette brushes and all that good stuff, and keeping their mouth as clean as we can. And institutions that have implemented policies that say things like oral care must be done every 2 years, every 2 hours, have a significant decrease in their ventilator-acquired pneumonia rates. The other thing that we found that actually dramatically decreases the chances that you're going to get ventilator-acquired pneumonia is actually if we elevate the head of the bed for 45 degrees, up to 45 degrees, for anybody who does not have a contraindication. So for instance, as long as you're not hypotensive, as long as you don't have a spinal injury, if you're tubed, you need to be sitting up. Increasing the level of the bed, putting them in a head of bed elevation position, dramatically decreases ventilator-acquired pneumonia. Another thing that we know dramatically decreases ventilator-acquired pneumonia is actually stress ulcer prophylaxis. So patients that are going to be ventilated for any period of time probably need to be started on some kind of H2 blocker. Another thing we know is very tight control of the glucose tends to decrease ventilator-acquired pneumonia, and that's why this has become another major tenet in ICU care, is typically keeping the glucose somewhere like between 80 and 150. And finally, for patients who actually get ventilator-acquired pneumonia, these patients tend to be in lots and lots of trouble, because most of the time when you get ventilator-acquired pneumonia, you get it because of microbes that are present in the ICU, and those microbes that are present in the ICU are oftentimes antibiotic resistant. So when we talk about treatment of VAP, once the patient actually has VAP, the big thing we're going to do for those patients is give them antibiotics, but it's really hard to say what's the right antibiotic for every case, because really the antibiotic should be driven by what's most prominently present in the particular ICU where the patient gets ventilator-acquired pneumonia. And your infectious disease physicians and your intensivists in a good ICU should be acutely aware of what the most common things they're seeing are, and how to eradicate those things with the appropriate antibiotics. Okay, Last but not least, when we talk about actually deciding to do mechanical ventilation, or when we're talking about any disease process and we're talking about the decision to control the airway, we need to know what things to look for when we're looking for somebody who's rapidly deteriorating. And I would suspect that most of the people that are watching this have years and years of clinical experience and are very used to looking at patients and can walk into a room and very quickly look at a patient and say, this patient is flowing, this patient needs to be intubated right now. What's not so easy, though, is identifying that when you're taking a test, when you're reading an exam and you're trying to identify, okay, what do they want me to see here? What do they want me to do here? So when we're looking at an exam and we're trying to make decisions about care, remember to look for those hallmark classic textbook things like you were taught in school. Look for things like the patient has rapid shallow breathing, the patient's got dyspnea and they're in a tripod position, the patient has accessory muscle use. Another big one is the patient has a change in their breath sound, especially like with asthma. Like if they tell you the patient's wheezing really bad and then 15 minutes later the patient's not wheezing anymore, you always got to ask yourself, is the patient getting better or getting worse? Same thing like with CHF or pneumonia. People with CHF and pneumonia, obviously as their disease process gets worse, a lot of times they get really, really noisy, and then as there's a decrease in movement of air, that noise will become less. Some generalizations about blood gases. In a patient who has a normal blood gas, when their blood gas changes to a pH less than 7.2, a CO2 greater than 55, or a PO2 less than 60, we usually use those as hallmarks for defining respiratory failure. And so at that point, somebody who was previously healthy but now has a CO2 greater than 55 or a PO2 less than 60, we need to start thinking about whether or not they need to be intubated. We also need to thinking about intubation in patients with an increased work of breathing. And the biggest thing, the number one reason why we intubate patients is fatigue. The reason that especially we intubate patients with those respiratory exhalatory type problems like asthma and COPD is because the patient is fatigued to the point where they can no longer sustain a minute volume. So when we talk about decreases in minute volume, remember that minute volume we said was made up of tidal volume and rate. So what we're looking for is, do we see a decrease in the minute volume? Remember, a patient who has a decrease in their tidal volume with an increase in their rate at the same time is not a patient who's getting better. That's typically a patient who is getting worse and flailing, and by definition is going into respiratory failure. In contrast, the patient whose rate is going down but their tidal volume is going up, that patient probably is getting better. So I'll say that again. The patient whose respiratory rate is going down but their tidal volume is going up is probably getting better. The patient whose respiratory rate and tidal volume are both going down is probably in respiratory failure or headed towards respiratory failure and probably needs some kind of intervention in addition to what you've already done. Okay, well that brings us to the end, finally, thank God, of our respiratory section. If you have any questions, feel free to email me. My name again is Anthony Baca. My email address is abaca@camanagement.org. That email address again is abaca@camanagement.org. And our website address is www.ca, as in clinical analysis, management.org. You can also find contact information there. In the interim, I hope that you have a great day.
I'd come for you, no one but you. Yes, I'd come for you, but only if you told me to.